It is a pleasure to invite Professor Patrick Mckiernan, who is a well-known name in hepatology, in pediatric hepatology. I have a long association with him, and he has been working as a senior consultant at the Birmingham Children's Hospital in the liver unit, and he has been the director of hepatology and professor of pediatrics at Children's Hospital at University of Würzburg. And he has his expertise in inherited metabolic disease and portal hypertension. Today, he is going to enlighten us on long-term outcome of pediatric liver transplantation. Over to you, Dr. Patrick Mckiernan.
Good day. Thank you for the invitation to speak. I just look forward to being able to meet you all in person, and the restoration of normal service for in-person meetings. I hope everybody remains safe. Here are my disclosures. I think it is now entirely appropriate that when we come to talk about liver transplantation in children, that we consider long-term outcomes. Here is an exemplar of the outcomes from the Children's Hospital in Pittsburgh, but this is the outcomes which are achieved by many experienced centers around the world. Pediatric liver transplantation is an extremely successful procedure with excellent long-term outcomes. And we can confidently predict that young children who are undergoing transplantation now will survive into adulthood. And we hope that they will, in adulthood, be able to achieve their potential. And as a result, how we think about transplantation in children has changed. We can no longer stick to the paradigm of considering just survival. That is no longer good enough because that is already established. With these improved results, we now need to focus on allowing children to achieve their potential. We want this improved survival to be associated with improved quality of life. We want them to achieve their potentials, whether that be in growth, whether that be in neurodevelopment, whether that be in educational experience, but they should achieve their full potential. We hope that most children undergoing liver transplantation will have children of their own and will live healthy and productive and long lives. Liver transplantation in children is still very dependent on immunosuppression. And one of the things that I will come back to is that with our current regimens, and here's an exemplar from Pittsburgh, for example, which involves some induction immunosuppression and long-term maintenance treatment with tacrolimus, which is a similar program to most centers around the world. Now, unless we change and develop new protocols, particularly new induction protocols, it is very likely that the great majority of children undergoing transplantation will require lifelong or significant long-term immunosuppression. And this would be something that I will come back to in this talk. Monitoring of children after liver transplantation obviously has a number of components. Firstly, we want to look at organ function, make sure that this is remaining stable. We want to monitor immunosuppression, as I referred to. We want to monitor the efficacy and any side effects springing from immunosuppression. And we also increasingly want to focus on those that would promote long-term and particular cardiovascular health, like lipid profiles, like monitoring of blood pressure. And as in many centers, one of the important monitoring in the long term is the use of protocol liver biopsies, which is now used by many centers around the world. So why might we see late graft dysfunction? I think the first two, biliary and vascular complications, continue to be difficult, and particularly for biliary complications, an Achilles heel of pediatric liver transplantation. I think, however, you would recognize that most of these complications, if they are going to occur, do so in the early stages after transplantation and are usually recognized at an earlier stage. Now, they can occur late, but they've usually been an evolution of something that's been there. Recurrent disease is, thankfully in pediatrics, something that we don't have to worry about too much, but it does occur. I think we all recognize that autoimmune liver disease, whether that's autoimmune hepatitis or sclerosing cholangitis, is more likely to occur after transplantation. And I think most programs have modified their immunosuppression to include long-term corticosteroids in the management of this group of children. And it's fair to say that recurrent disease is rarely associated with significant clinical disease, and these are rare indications for repeat transplantation. Malignancy can occur, and of course there's this very interesting and relatively unique recurrence of PFIC type 2, where recipients can develop anti-BSEP antibodies, which reproduces the phenotype. This probably occurs in less than 10% of children with PFIC2, but it is very important to prevent. And this group of children are probably best managed with increased immunosuppression to prevent any recurrence of disease, because once this occurs, it is really quite difficult to treat. As I referred to, one of the very important aspects of monitoring graft function is liver biopsies protocol. And this is what we like to see in normal post-transplant biopsy. But sadly, that's not the common phenomenon. And this is what we're much more likely to find, this kind of a chronic hepatitis with often some interface activity, accompanied often by fibrosis. Now, my colleague, Dr. Evans, is now 15 years ago, described the early experience of protocol biopsies in the Birmingham program. And you can see that after 1 year biopsies, most children did not have fibrosis. But by 5 years, a significant group were having fibrosis. And by 10 years post-transplantation, nearly half of children had either moderate or severe fibrosis. And again, these were on protocol biopsies on children with relatively normal liver function tests. What we found within that group, where the biggest predictor that we could find of fibrosis and hepatitis was autoantibody positivity. And I think many of you know that now this phenomenon has been found in almost every pediatric program around the world that's looked for this. Children on conventional immunosuppression tend to develop hepatitis and fibrosis. Now, we have some recent insights into this from a very fascinating study called the IWID study. I think the IWID study, the aim of this study was to try to withdraw immunosuppression so that we could see whether, children are tolerant. And I think it's salutary to look at the figures involved. Nearly 3,000 patients were eligible. But of those, once they were looked at a little further, only 600 met the criteria. Of those, only half were logistically feasible. Some of them agreed, some of them were approached, and about half agreed. So in practice, only 5% of the total cohort who might have been available to the study of withdrawal of treatment were actually enrolled. And I think it's important to keep that in mind. Now, those children who were enrolled underwent a protocol biopsies, and largely they had normal liver function tests. And as in the Birmingham program, the same thing was found. A significant number of these children had significant inflammation, a significant number had fibrosis, and even some of them had moderate to severe fibrosis. This group did a really sophisticated cluster analysis where they looked at inflammation, fibrosis, and perivenular fibrosis. And we're able to recognize 3 clusters of children in this manner. Cluster 3 were actually children who were relatively normal, whereas cluster 1 were the group who had the group that were reported from Birmingham having perivenular inflammation and fibrosis, whereas cluster 2 had fibrosis alone. And they did some very sophisticated analysis of gene expression within the cluster. And what they found was that the group who had post-transplant hepatitis or chronic hepatitis of the allograft had an increase in gene expression that were associated with T-cell rejection. So although these biopsies were not typical of T-cell rejection, the genetic the profile of the cells involved suggest that rejection was that T-cell rejection was a significant component of this inflammation. And donor-specific antibody positivity and donor-specific antibody titers were also associated with this inflammation. So this chronic hepatitis of the allograft appears to be associated with immune activity, both T-cell mediated and donor-specific antibody mediated as well. Now, we didn't know this when we did the original program in Birmingham. We knew that these children were managed with monotherapy with cyclosporin, and we made two changes. We introduced tacrolimus, but we also continued low-dose corticosteroids. And then 10 years later, we came back to look at the outcome of a group of children who've been treated with a more up-to-date profile. And they had very similar biodata. Here was their biochemistry at 5 years and 10 years. As I say, most of them were normal, but as you can see, those treated with the new regimen with low-dose 0.1 milligram per kilo of prednisolone tended to have more normal transaminases. They had lower transaminases. The big difference was in their biopsies. Whereas in the historical cohort, less than half of them had normal biopsies without inflammation at 5 years. In the new protocol, this was the case in 70%. And this was maintained at 10 years. So using low-dose corticosteroids or increasing immunosuppression made chronic hepatitis, the allograft, less likely to occur. And it did decrease the amount of fibrosis, but this was less impressive than the decrease in inflammation. So given that immunosuppression seems to be important, not surprisingly, compliance with adherence to immunosuppression is a very important predictor of outcome. And we do know that young people do tend to become non-adherent, both to the clinic attendance and with their medication with time. And this is not a benign phenomenon for most of them. One very useful and pragmatic way to measure adherence to compliance is measuring the standard deviation of serial tacrolimus values to create a variability index. And this is a very useful measure of adherence. And as you can see here, the more variable tacrolimus levels are, the greater the likelihood of rejection is. So this is a very pragmatic way for predicting and detecting non-adherence. So why do young people who've grown up in this very supportive environment, why do they become non-adherent? And one of the things is obviously is time. People become a little blasé. The longer they are away from transplantation, the older they are, the more competition with things to do in their life, and the more likely they are to become non-adherent. But the big and important factor are psychosocial. Those who come from the most challenging environments are more likely to those to have to be non-adherent in the long run. So what can we do about it? It is important that we're not blasé about non-adherence, and that we don't accept this as the go-to. We can do something about non-adherence. Children who are non-adherent now may not necessarily be non-adherent for the rest of their life. Big challenge in managing non-adherence is actually detecting it in the first place. We need to be upfront about this. We need to discuss it as a possibility with our young people and their families. We're not going to make them non-adherent by asking these questions. I think that's important to recognize. And as I've referred to earlier, pragmatic measures like tacrolimus variability index are very important ways of detecting that there is non-adherence. And then detecting it is important to talk about, recognize the reasons there are, recognize if there are resource issues that we can do something about, recognize if there are misunderstandings. It's also important to say that if we do detect non-adherence, we can offer closer, more frequent monitoring so that families do get feedback as to whether or not adherence is changing. Because I think if people are being accused of non-adherent and then they address this, it's very important they get feedback to say, well done, we've seen this, your tests are better, your variability index is decreased. And involving them and their families in the monitoring is very important. education is key. And increasingly with young people, measures such as texting or using other sorts of social networking can be a better way to approach this. And this is something that they may be more likely to respond to. But a key factor, or the fact is that we're looking after children who had liver transplantation. They are children, but we don't want them to be children for all of their life. We need to transfer their care into adult physicians. And this is an important and challenging issue. This is the definition of transition, which has a number of important things. It's purposeful, it's an active process, it's planned, where adolescents and young people are changed from a child-centered to an adult-oriented healthcare system. And this is a normal and expected progression. However, it has and continues to be challenging in some cases. This very important paper from the Nonadherence unit in the UK looked at early experience with transition following renal transplantation in childhood, and it was a disaster. Within 3 years of transfer, 8 of the 20 transplants have been lost. And this was unexpected. These were not grafts that had been doing particularly badly. And it did look as if non-adherence was a significant factor in this occurrence. Early experience with liver transplantation, again, was not very encouraging. Here were 14 consecutive patients undergoing transitions, and 4 of those patients died in the next 4 years. And you can see that of these patients, they weren't highly compliant at the time of transition of aspergillus, but their variability, which reflecting their adherence, got worse with time. Their liver function tests got worse with time. The number of rejections increased with time. So clearly, this is a challenging time, and it's very important that we make this as effective and safe as it is possible to do it. And we now have enough information that we can make some suggestions for guidelines for how an effective transition program can be. And the most important factor is that the pediatric and the adult service are both involved in this. And the young people in the family can see the pediatric and adult center working together, because families have grown up to trust their pediatric caregivers, and they and their children are worried about a transfer of care. They feel they're going to lose out. They feel this is going to be an unfamiliar and unfriendly environment. And for them to recognize that the adult and the pediatric carers on the same side is very important. And this is a very important message. But other than that, the model of transition, we do not have to be too dogmatic about it, because if it's well planned and it's well executed, the actual model you use is not so important. Well, there are some components that need to be incorporated in this. Overall, this needs to be a flexible timing. Just saying you're 18, 16, etc., that you have to be transferred is not a good, as a single cutoff point. We need to use a named person so that there's a go-to person that families can talk to during the process. And again, then we need to individualize this depending on the individual's ability, on the center's experience, on the adult center's experience, and also need to fit it in with other issues in young people's lives, such as schooling, such as education, etc. And again, as with this group of people, the use of information technology and social networking can make any process more efficient with this group. My colleagues in Birmingham had a chance to look at, a couple of years ago, some of the very early pediatric transplant recipients and where they were more than 15 years later on. Now, it's important to recognize that these were children who were transplanted more than 30 years ago in general, and obviously survival is not what we'd expect now. And unfortunately, some did die after transfer to adult service. But overall, of those who were followed up, the outcome is actually very encouraging. 80% of them had normal graft function. Renal function was reduced in a third, and some had gone on to have a renal transplant. And hypertension was common, as was a modest amount of hyperlipidemia. Interestingly, possibly reflecting the immunosuppression used at that time, there was no diabetes in this group. Psychosocially, they were doing well. 80% of them were in employment or education. and half were married in a relationship. So this was without the benefit of a structured transition program, which hadn't been established when this group were transferred. So the outlook for this group can be very positive. So if I can conclude that overall pediatric liver transplantation is a highly successful option. Long-term high-quality survival is the rule, and we need to be giving children the opportunity to achieve their full potential. We know chronic hepatitis of the allograft is common, and maintaining adherence to immunosuppression is an ongoing challenge which we need to be vigilant. Transition to adult care is a time of increased risk that should be anticipated, planned, and management. Thank you for the opportunity to speak.
Thanks, Patrick, for the excellent presentation. It's been a pleasure to to understand how things move and all about the fibrosis. What would you recommend? Do you recommend long-term low-dose steroids or still monotherapy with tacrolimus?
I think it's hard to know. I'm favoring towards low dose corticosteroids, particularly if there's hepatitis of the allograft. Now it may be that if you never use steroids in the first place, if you have a really true steroid-free regimen, that then you may be able to stay clear of steroids in the long run. But in practice, most of those children had steroids for the first few months after transplantation anyway.
Yep.
And it may be that in some way that has primed them. So I do think for many children, a small 0.1 milligram per kilo dose of low-dose steroids is probably necessary. Now, there may be other alternatives to that. Maybe a low-dose azathioprine may work just as well, or using slightly more tacrolimus might work just as well. But I think probably low-dose tacrolimus, with levels of about 2, and a small dose of steroids is probably for many people. But again, I'm a great believer in protocol biopsies, and if you've got a 5-year protocol biopsy looking normal with very little inflammation, then I think whatever you're doing is working.
Yeah, fantastic. Thanks, Patrick. Just last question. I think we look at the AST, ALT and bring down the tacrolimus to 3, 4, 2. When the enzymes are normal, long-term down the line in 5 years, how we could taper the immunosuppression, tacrolimus? What is the best tacrolimus level? Whether it's 2, 3, what is it?
So I think this is difficult. I think I tend to, not to push the level too much, when I think you have some people who have, if you got normal liver function tests, particularly if you're on a little bit of corticosteroids, I think around 2 is probably good for many patients, but not all are the same. Some seem to need 4 to 6. It's quite individual, but I'm cool about, bringing children down to around 2, but I feel much more comfortable doing that if I do an occasional biopsy on them.
Oh, fantastic. Thanks a lot. Thanks a lot, Patrick. Okay. So I think we will conclude that having a protocol biopsy is always good.
I think so.
A tiny bit of steroids would probably do some help.
Yes.
With this, I would conclude. Thanks a lot, Patrick. It's been nice seeing you.